Hello, everyone. I am Dr. Noel L. Espallardo, a fellow of the Philippine Academy of Family Physician, and presently I am the chair of the research committee and the chair also of the publication committee of the PAFP. Currently, I'm also the editor-in-chief of the Filipino Family Physician. So, in this session, I will be presenting tips on how to do or how to conduct a case control study. And this is the outline of my presentation. First, we'll try to define what is a case control study and why do we do it. Then we will discuss the steps in doing a case control study. And we'll try to focus on the areas where biases can be introduced, such as defining the population, sample size computation, and then I will be sharing some tips on how to analyze the data and then maybe one brief slide on how do you write the case control study report. Okay, so I hope we will have a good learning experience in this session. Risk factors or prognostic factors are important information that a family physician should know in order to plan for the appropriate management of their patients. With regards to risk factors, we can use such information in order to inform the patient whether to avoid or promote such behavior because that factor could lead to a decreased probability of developing the disease or having a bad outcome as far as prognosis is concerned. However, when you study a risk factor or a prognostic factor, the ideal design is to look at those patients or look at those persons who have the risk factor or the cohort, and then you observe, you compare them to those without the factor called control and observe them forward in time. Unfortunately, if you observe these patients forward in time, it may take a long time for the outcome to develop. And therefore, if you're doing your research as a resident physician or a medical student or somebody in training, it will be difficult for you to complete the project within your timeline. So an efficient solution for this is the case control study. And in such a study, what you do is to select a sample of subjects who already are considered to have the clinical outcome. They're already called cases. And then you also get a sample of subjects who do not have the outcome, called the control, and then observe them backward in time. Look at whether they were exposed to the risk factor prior to the development of the outcome or the disease. No? So this is called the case control study design. And it is diagrammatically represented this way. So in your practice, hospital or clinical practice, what you will do is to identify cases, meaning those patients who have the disease or the outcome, and then you compare them to the controls, meaning those patients who do not have the disease or the outcome, and then look at their records or look at their history. Have they been exposed to this factor 3 years, 2 years, or 5 years ago? The same thing with the control. Have they been exposed to this exposure or to this risk factor 3, 2, or 5 years ago? And if there is really an association between the risk factor and the development of a disease in the cases, what you will expect to find in your results of your study is that there will be a higher proportion of those patients in the cases who had the exposure as compared to the control who will have less proportion of patients with the exposure. So this somehow establishes the association between the exposure and the clinical outcome. So that is a case control study design. All right, now why do a case control study design? Well, as I've said earlier, if you're going to do a cohort study, then it will take a long time. No? So the advantage of doing a case control study is that there is a short observation period. Okay, so you do that for a studies of multiple of risk factor or prognostic factor because of the short observation period. Establishing the association between these factors and the outcome or development of disease, case control study has a better advantage on that. So if there is a long period, no, between the development of the disease or outcome. The other advantage of a case control study is that you can study multiple risk factors for a single outcome. In the real world setting, patients, the lifestyle practices of patients would somehow put them at risk of exposure to multiple risk factor. And so this interaction of multiple risk factor can be addressed in a case control study design. Now, this study design has actually been the design used to establish the association that is now very well established association between cigarette smoking and lung cancer. Right? Now, at the time that this association was published, way back in the 1950s, Dahl and Hill has been criticized for using this study design because at that time, cohort studies are the ones that are being accepted as a way to establish an association between a risk and a clinical outcome. But Dahl and Hill was able to show that this study design was as good as a cohort study design, as long as the other biases are addressed. And that is what we're going to discuss a bit later, addressing the biases in a case control study. So here's the bias. Number one, of course, selection or sampling bias. If we're getting the cases in control from the different population, then we might be introducing bias, because different population will be exposed to different risk. In other words, when you do a case control study, you select a population, either the population came from the same geographic location or from the same hospital. Second is a measurement error. Sometimes because case control study is looking backwards, you ask the history whether this patient has been exposed 2 years ago, 3 years ago, or 5 years ago. Measurement error may be very difficult to address, especially when there is a problem of recall among patients. So one way to do that is to look at data that are routinely recorded, that will not depend on recall from the patient, but is recorded data. Unfortunately, if you do recorded data and you rely on chart review, there are some risk factors or patient behavior that is not routinely recorded in the chart. So missing data is a bias also of a chart review. Confounding is also another issue that you might want to examine. That might introduce bias. A confounding is something like one risk factor might affect the association of that specific risk factor by another risk factor. For example, coffee drinking and smoking. Now, we all know that smokers are also coffee drinkers, and heavy coffee drinkers can also be smokers. And if we're able to establish association of smoking and lung cancer, then there is also a probability that using the same data, we will be able to establish coffee drinking and smoking on the assumption that most of those smokers are also coffee drinkers. But coffee drinking is just a confounding there. So it doesn't really show that coffee drinking would lead to lung cancer. So confounding is one issue that you would have to address in a case control study. Okay, so these are the steps in doing a case control study. Number one, you define the problem. What is it that you're trying to answer? Once you have established your problem, develop the objectives. After developing the objectives, define the population, define the cases and the control, and where you're going to get these cases and control, and how many are you going to get the cases and how many are the controls. And then define the exposure. What will be the risk factor that you will investigate? After defining these things, then collect the data and analyze the data. And finally, once you have analyzed the data, you're now ready to write the paper. So that is the steps. Those are the steps in doing a case control study. Okay, so let's start with step number one. Define your problem. When you define a problem, the problem is usually composed of PEO, the patient or the population, the exposure or the risk factor, and O, the outcome, the clinical development of a disease or the outcome of the disease. All right. So for example, in this particular example that we're going to use as a demonstration, by cross-sectional study, it has been shown that those children that are those mothers that have more than 3 children have a higher probability of developing postpartum hemorrhage as compared to those mothers who have less than two or less children. Okay, so parity is a risk factor for postpartum hemorrhage. Now, supposing you're now a resident physician in a provincial hospital or a practice-based program, and in your provincial hospital, you also rotate in the OB department, you might want to ask yourself, since you are also seeing patients on prenatal care, what about anemia? Is anemia a risk factor for the development during prenatal checkup? Anemia is a risk factor ba for the development of postpartum hemorrhage? No? So that is now one example problem. No? So is anemia during prenatal checkup a risk factor for the development of postpartum hemorrhage upon delivery? Now, why is that important? No? If we are going to ask this question of anemia as a risk factor for postpartum hemorrhage, why is it important? Well, if you know that it is a risk factor, then during prenatal checkup, and if you see anemia among your patients undergoing prenatal, then you can introduce some aggressive correction. And you can also advise the patient that, if this anemia is not corrected, the probability of postpartum hemorrhage whenever she delivers 6 months or 2 months from now will be very high. So you can use that information to advise the patient. It can also advise our clinical guidelines or pathways on what kind of intervention to give to our patients. No? And do you get this information? Well, you can get the hemoglobin level during prenatal checkup in the record section, no? Since most of these patients would have a prenatal record checkup. You can also get the record or information regarding postpartum hemorrhage in the delivery room. No? So you can just get it and try to study the charts of these patients and establish the association between anemia during prenatal checkup and whether there is a postpartum hemorrhage or none upon delivery. All right, so if that is now our problem, association or is anemia during prenatal checkup a risk factor for the development of postpartum hemorrhage, then you now develop your objectives. No? When you develop your objectives, it has to be specific, measurable, attainable, relevant, and time-bound. No? So SMART criteria in developing the objective. So going back to that example, the objective of the study would be something like this. No? Determine the association between anemia and during pregnancy and postpartum hemorrhage. Second is, aside from anemia, to determine other risk factors to the development of postpartum hemorrhage that might also affect the anemia, association of anemia and postpartum hemorrhage. So if this is the objectives that I have, here's one advice that I would give you. At the stage of objective development, you already develop your dummy tables or hypothetical results. And make sure that your dummy tables or hypothetical results will be answering your research objective. No? So to answer this association between anemia and postpartum hemorrhage, this table, anemia, no anemia, the 2x2 table, anemia, no anemia, with postpartum hemorrhage, no postpartum hemorrhage, this is going to be your main dummy table. All right? And if you have this 2x2, you'll be able to get the odds ratio and its confidence interval. So we will discuss that later on. Now, of course, aside from this main table that will address your objective, you may also need a table that will describe your population. So again, this is my advice, firm advice, that when you develop your objective, you already develop your dummy table or your hypothetical results. And why is that? I will emphasize that later on, why it is important to develop this hypothetical results or dummy table at this early stage. All right, so after developing the objectives, your next step in the dummy tables, your next step now is to define the population. When you define the population, you should be defining both the cases and the control. So usually case definitions are based on disease definition. So you have to be very careful. I mean, there are standard disease definitions, so you should not have any problem about this. For example, postpartum hemorrhage. In our example, postpartum hemorrhage is defined as a hemorrhage or estimated blood loss during delivery of greater than 500 ml. All All right. And then, of course, it's up to the physician on how to estimate blood loss. Anemia is also defined as a hemoglobin of less than 100 during prenatal checkup. So the definition of the cases and the exposure is a bit easy. No? So the definition of the control would be just the opposite of the cases, meaning the absence of postpartum hemorrhage is if the estimated blood loss is less than 500 ml. And this definition is usually included in your inclusion and exclusion criteria. Okay? After defining the population, you're now defined the cases. Now you're going to define the control. And when you have the control, usually it's the absence of the definition of, let's say, case. No? Let's say postpartum hemorrhage. A postpartum hemorrhage is defined as blood loss, estimated blood loss during delivery at 500 ml, then the control should be defined as an estimated blood loss during delivery of less than 500 ml. Okay. Now, of course, there are some principle in the choice of control. As much as possible, they have the similar characteristics in terms of age and gender to your cases. No? If you do this, then you might be able to avoid the biases that we had discussed earlier. And as much as possible, the control should not be less than the number of cases. Because in the real world, a lot of people are healthy, or a lot of deliveries are not really developing into a postpartum hemorrhage. No? So the controls in the real world population is actually more than the cases. And this information is basically important when we decide later on the case to control ratio. And we will try to tackle that a bit later. Okay. In order to avoid sampling bias, as I have mentioned earlier, when you select your cases and control, it has to be from the same population base. When I say same population base, patients should be coming from the same province or from the same region, or you get your cases and the control from the same hospital. And that is called a nested case control study. So when you select your controls and cases in the same population group, that is called a nested case control study. So hospital-based case control study offers some advantages as far as a population bias or selection sampling bias is concerned. So these are the potential hospital population database, the hospital records. If you have a disease registry in a hospital, so I'm sure the delivery room should have a delivery registry. So that should be a good database from the hospital. Well, HMO database can also be used if you're doing an HMO-based study. No? But for our example, the disease registry in the delivery room and the hospital record would be a good source of information for the cases and the control. Okay, the next question is, should you match cases and the control? If the requirement of a good case control study is that the cases and control should have a uniform characteristic such as age and sex in order to avoid the confounding, do you have to match? No? Matching is a process wherein for every case with a, let's say, a 35-year-old female, no, who you defined as a case, then there should also be a certain number of 35-year-old female as controls. No? Now, since in our example of postpartum hemorrhage, all of them would be female, we're now only about matching for age. No? So we can do individual matching for age. For every 35 or 40-year-old female who is defined having a postpartum hemorrhage, then we'll also select samples or subjects who are also 35 or 40 years old who do not have postpartum hemorrhage. That is called matching. Unfortunately, matching is time-consuming and costly at times, no? Especially when the parameter that you're using for matching is something like a laboratory parameter. So that will be more expensive. The other solution is to do random selection. No? So if you have a list of cohort of subjects or list of subjects in the delivery room that does not fulfill the criteria of postpartum hemorrhage, then you can just randomly select from that list. So random selection and then later on, if there is really differences in your random selection, there is differences between the case and control, then you can just do a stratified analysis for confounding later on. So this random selection can actually save you more time and difficulty as compared to matching. So random selection would be a good alternative to matching. The next thing that you need to answer regarding selecting the population is how many subjects do you need to gather? In the sample size computation for a case control study, it depends on the estimate of the odds ratio. The odds ratio is, let's say, the probability that the patient will develop the outcome if he has or she has this risk factor. Okay, so the larger the odds ratio, the lesser the sample size. The smaller the odds ratio, the greater the sample size that you will need. Okay, now how do you get this estimated odds ratio? This is based on previous studies, studies from different population or previously published studies. You can use that as a reference in estimating your odds ratio and then using that for your sample size computation. The other question that you need to answer is that for every case, if you have, for example, if you have computed that you would need 50 cases, then how many controls will you need? The optimal ratio between the cases and control is 2 to 4 control per case. So for every one case should be 4 controls. So if you're able to identify based on your sample size calculation, you need 25 cases, then therefore you need 100 controls if your ratio is 1:4. Okay, so how do you demonstrate this sample size computation using EpiInfo? Using the function of StatCalc, you can use this unmatched case control study. If you click this function, then it will lead you to here, and it will these are blanks initially, and then you just fill in. So at 95% confidence interval, 80% power, and then the ratio of control to cases is 3. So 3 controls per every case, and you're going to get this from previous studies, the percent of controls that are exposed to the exposure. That means the prevalence of anemia during pregnancy. In one study, World Bank study, the prevalence of anemia is about 30%. And then the estimated odds ratio is that if you have anemia during pregnancy, then the probability or the odds that you're going to have postpartum hemorrhage as compared to those without anemia is 4 times. This is also based on a previous study. And when you encode this number, then you will have these samples. You will need 27 patients who have postpartum hemorrhage and 79 patients who do not have postpartum hemorrhage. So if this is the sample size computation, the next step, you have now defined the population, you have now defined the control, the cases, and you have now decided on how many cases and how many controls to get. The next is to define the exposure. In our example, the exposure is anemia. So definition of anemia is a bit easy. It's a standard that the hemoglobin level of lesser than 100 milligram per DL during prenatal checkup is considered to be anemia. And you can get the hemoglobin level at the prenatal record of your patients. So you have defined now the exposure risk factor, which is anemia. Okay, after defining your cases, controls, and then of course the exposures, the next step is to develop your data collection form. When you develop your data collection form, make sure that you only collect relevant information. As much as possible, avoid having 2 pages data collection form. In this particular study wherein we will try to just establish the association between anemia and postpartum hemorrhage, then just getting relevant information will be enough. No need to get so many information on the patient or on the hospital. Okay, so just develop a simple data collection form that will obtain the data necessary based on your hypothetical table or results. Okay, So collect the data, develop the data collection form, then collect the data, go back to the record section of patients who delivered in your hospital, and then go back to the prenatal checkup of that patient, and then see if there is anemia, and then during delivery, try to determine what is the estimated blood loss based on the delivery records. Okay, so the next step is to analyze the data now. Based on the records, you were able to establish who developed postpartum hemorrhage on delivery and who did not. And then based on the records, you also were able to obtain during their prenatal who had anemia and who did not have anemia. So if you have this table now, this is 2 by 2. The formula for odds ratio is A multiplied by D divided by B over multiplied by C. All right. And you'll be able to get the odds ratio. The odds ratio is interpreted as the odds of developing the disease if you have anemia compared to the odds of developing the disease if you don't have anemia. Okay, so that is called the odds ratio. All right, so the odds ratio, the interpretation is that if the odds ratio is 2 or more, then the odds of developing the disease, if you have the exposure or risk factor, is higher. If it is less than 1, then the odds of developing the disease is lower. And if it is 1, then there is no association. All right? And then you get the sample confidence interval. All right? So that is how you interpret the odds ratio. If the odds ratio is more than 1, then the development of the disease or the clinical outcome is higher if you have the risk factor or prognostic factor. Okay, so let us now go with the data analysis, going back to your hypothetical results or dummy table that we have developed when we develop your objectives. The purpose of your data analysis is to fill in this dummy table, okay? So that you will now have a directed data analysis rather than exploring your data. You have now a purposeful data analysis strategy. Okay, so again, I'm recommending EpiInfo when you do your data analysis. And in EpiInfo, once you open your data analysis classical format, you have this. Now, on the left side, you have the commands, and on the center, you have the outputs. So there is a means command on the left side, and on the center, you just click means, and then on the center, specify the age, specify the cases or control, and then you click OK. So when you have that, the EpiInfo will now give you this data. No? So in this particular example, the mean age of cases will be about 33.25, and the mean age of the control is about 34.52. And this is the standard deviation. All right, so these are now your observation data, and later on you will transfer this to your hypothetical table results. And if you click the arrow down button here, what you will see, if you go down, you will now see the t-test, no? Which is the comparison of the age between the two groups. So the t-test here is a p-value of 0.21, no? Or 0.2. Okay, so you transfer that information. You also do the same for mode of delivery and the other observation parameters. And then in the mode of delivery, you also get these numbers. Transfer this also to your dummy table. And then you have your chi-square testing. Transfer that also to your dummy table. And you now have these results. No? So for the odds ratio naman, you also will be able to compute that using EpiInfo. And you now transfer all of those information to your dummy tables. So here is now the result of your data analysis, no? That in terms of mean age, there is no significant difference between the two groups. The 33 mean of those with postpartum hemorrhage is not statistically significant from the 34.5 mean of those with no postpartum hemorrhage because the p-value is 0.21. For the p-value to be significant, it has to be less than 0.01. Okay. Now, in terms of the main research question, is anemia associated with postpartum hemorrhage, as you can see here, the odds ratio is 3.8 or around 4, which means that if the patient has anemia during prenatal care, then the odds that they're going to develop postpartum hemorrhage is 4 times the odds if they don't have anemia. No? 4 times the odds of developing postpartum hemorrhage as compared to when they don't have anemia. Okay, so that will be a good information to advise the patient during prenatal checkup that if they have anemia, they should be able to comply or adhere with the medication, no? Iron supplement and some dietary advice, so that the anemia will be corrected. So that at term or during the time of delivery, postpartum hemorrhage will not happen or will not occur because it increases, no, if they have anemia. All right. Well, these are the other odds ratio for the other risk factor like parity, and the manner of delivery, whether CS or cesarean section or normal, is not associated with postpartum hemorrhage. So it's basically maternal characteristics that are more associated with postpartum hemorrhage rather than manner of delivery. Okay, so having this data in your results section, the next step now is to write your paper. And in writing your paper, the standard for writing a case control study design is called the STROBE, no? Strengthening the Reporting of Observational Studies in Epidemiology. I will not go specifically to this. You can download this in the internet. It's available for free, full text. And you will be able to see that in the second or third page of this paper, you'll be able to see the outline on how you write your case control study design. Okay, so I hope I was able to share you some significant information and tips on how to do a case control study design. So if you choose this study design for your research project, you can always go back to this presentation and try to get some further advice and tips in developing your protocol and finally developing your or conducting your case control study. So good day, and thank you for listening. I hope I was able to impart some information or significant information for your research project.